Assalamu alaikum, the long clinical consultation day. First scenario, Mr. John Smith, 70 years old, presented with short breath for the last 2 months. His vitals are normal apart from his saturation is 93. Please take history and examine the patient. You can start.
Hello, I am Dr. Mohammed. I am doctor in clinic today. With me, Mr. John Smith, 70-year-old.
Yes.
Today, Mr. John, we are here to discuss some health issue for you. I will take some history and do some examination, and all of our talk will be confidential if you don't mind. Okay.
Okay.
Firstly, Mr. John, how are you now? Are you okay?
Yes. Okay.
Okay. How much do you know about your condition, please, to be on the same page?
My condition is started around 2 months ago. I feel a shortness of breath, like tightness in my chest with shortness of breath, mainly when I'm walking, like little distance or climbing a stair or doing any exercise. I feel this. I don't know what is this.
Sorry for that, Mr. John. You mentioned this started 2 months back, right?
Yes.
It started suddenly or gradually?
It started gradually, but now is increasing.
You mentioned increased by effort and climbing stair, right?
Yes.
Anything decreased when you become rest or become lying down or anything?
No, no. I didn't notice that something decreased, but I noticed that only with exercise it increased.
Okay, sorry for that, Mr. John. During at night, you are sleeping how much below?
2 below.
Did it increase this 2 months or the same since a long time?
What?
This is the same since a long time or increased the number of pillows now this last 2 months?
It is the same.
Did you notice during sleeping you are awake searching for air?
Sometime.
Did you notice any increase leg swelling now last 2 months?
Mild. There is swelling, but mild in my both leg. And also
The same.
sometimes I feel tired, and sometimes I feel like dizzy.
Sorry for that. This dizzy during standing up or any time, or you noticed it any in special situation?
Uh, Sometimes with exercise also I feel more dizzy.
Sorry for that. Did you lose any loss of consciousness?
No.
Did you notice this shortness of breath started after any chest pain before these 2 months?
What?
Any chest pain before started this complaints?
No. It's coming together.
Coming what?
Together. Yani shortness of breath is start first, but later on I feel chest pain.
Okay. This chest pain, how much? Can you describe it? It is like heaviness or stabbing or
Like discomfort.
any refer to any go to any area of your chest, your back, your arm?
No, it's only in my chest.
How much you score it from 1 to 10? How much severe?
It's like 4 or 5.
I will offer for you any painkiller now, okay? Suitable painkiller, okay?
Okay, thank you.
Any feeling of heart racing?
Yes, sometime.
Is like this regular or irregular?
I feel it. My heart is like racing.
Racing?
Yes,
Okay. Regular or not regular like my definition now?
regular,
Any cough?
mild, mild dry cough, but not
Any
too
phlegm?
much. No, dry. No,
Okay. No
no,
coughing of blood?
no.
Okay. I mentioned no loss of consciousness, right? Only dizziness.
Yes, yes,
Okay. Anyone noticed you are more pale nowadays?
no,
Anyone noticed you are have yellow eye?
no,
Any headache?
no,
Any change of your weight?
no,
Any weather preferences?
no.
Any lump or bump in your body? Swelling in your body?
No.
Any swelling around your eye?
Only that mild swelling in my both foot, my both leg.
Yeah. And you mentioned the same both legs, right? No difference between
Yes.
together,
No.
right?
Same.
Okay.
Yes.
Any, any joint pain?
Mild joint pain in my both
Where
knee. In my,
your both knee?
yes.
Since when?
This is since long time.
Any swelling or hotness around?
No.
Any diagnosis before hospitalization or any GV diagnosis?
No.
What you are doing for this joint pain?
Sometime I visit my GB and taking some topical and is relieved.
No pain killer at all?
No, I visit my GB and uh, give me topical, some topical to apply in my knee, and I improve on this topical, but it's coming again, goes and
Oh,
coming. This is
it is
like
there now?
for long
This
time.
pain, this pain is there now?
No, now it's okay.
Okay.
Now
Any
only
rashes?
my
Yes.
what?
Yes, yes, I am hearing you.
Now only my problem, my shortness of breathing that is bothering me too much, and I am worried what happened to me.
Sorry for that. We will try to help you today, inshallah. Any rashes or skin lesions?
No,
Any family history of note? Any past medical history, long-term diseases you have?
um,
Diabetes, hypertension, anything?
yes, I have diabetes for around 6 years and on medication,
What medication,
but it
please?
is control. I don't know the name, but it is control.
Insulin or tablet?
No tablet, oral.
Okay. You last reading 3 months, okay? How much?
Six. My HB1C is 6.5. That is control.
Okay. Any other disease, any other long-term condition?
No,
Any family history of note? The same?
no,
Any family history of sudden death in early age?
no,
Any allergies?
no,
Any travel history soon?
no,
Sorry for this question, any illicit drug?
no, no, no,
Any blood transfusion?
no,
Okay. Um, James, do you smoke?
no,
Any alcohol?
no.
What's your job, Mr. June?
What?
Your job?
Now I am retired.
Okay. How much this affect your daily activities?
Now even I cannot do my simple work that I cannot go to the market and for shopping. I feel it very difficult. I
Sorry
do
for
it,
that.
but it's very difficult.
Sorry for that. We will help you today, inshallah, and support our social worker and our team.
Thank you.
Sorry for that. Any tummy pain?
No,
Any frozen urine or change of your water work?
no.
Okay. Any bowel work changes?
Any what?
Bowel work changes?
No, no, no.
Okay. Can I examine, please?
Yes.
Firstly, I need to generalize the patient how it look. Any cachexia, anything?
No,
Okay.
normal.
Okay. How is his vitals now? The same?
Same.
The pulse is good volume or low volume and regular or no?
Pulse is regular.
Any posture changes during standing? Blood pressure?
Uh, change in, you mean change in pulse?
Blood pressure decrease more than 20 mercury?
No, no, no. No change.
Okay. His hand, any sign of infective endocarditis, genuine, splinter hemorrhage, clubbing,onychia, sign of anemia, pallor?
No, 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 no anemia.
How's his pallor or jaundice in the eye?
No pallor, no jaundice.
How's GVB?
What?
GVB.
Normal, not raised.
Okay. Any lymph node there?
No lymph node.
I need to examine full heart from the apex. The site is okay.
Yes. Okay.
Okay. Sound S1, S2. Any murmur? Any adventitious sound? Any gallop?
No normal, but there is ejection systolic murmur um, radiating to carotid area.
In the first aortic area?
Yes.
Okay.
For
Uh,
pulse also character is slow rising pulse. For pulse character.
Slow rising. So
Yes.
I will do the water hammer pulse. I will ask him about shoulder pain. Then I arm and put my hand on the pulse and on the mid arm. Any collapsing?
No.
I will check the back of the basal of the lung. Any rails?
No.
I will check abdomen. Any swelling there? Any
No.
ascites? I will
No.
do shifting dullness. Okay. Palpable kidney.
Normal.
I will check his lower limb about how beating edema or non-beating equal swelling.
Mild. No. 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 Mild swelling.
Mild swelling. Okay.
Yes.
No
Yes.
difference between together. No rashes.
No.
Okay. I will ask you are driving, Mr. John.
Yes.
Okay. How much is affecting you?
Only sometime because of dizziness. I cannot
Two
drive.
minutes left.
So these days
Yes,
I already stopped driving.
yes, better. I'll highly advise you to stop until we fix this. I asked it before, no loss of consciousness, right?
Yes.
Okay, okay, Mr. John. Any vision problem?
No.
Any sore in your eye or mouth? Anything there?
No.
Okay. What's your concern, Mr. John?
Only I want to know what is this? What happened to me?
I appreciate your concern, Mr. John. After taking history and examination, we have high possibility of a problem called aortic stenosis. This is there is some gate on your heart become more narrow and affecting your function of your heart and cause the symptoms when you do any effort. And that's why I am advising you to stop driving until we fix it because sometimes can cause loss of consciousness. Okay, we will share our we'll take doctor the heart doctor will share the team and start to put the plan. We will admit you until we finish our imaging and labs. And there is some possibility to maybe need the surgery, but this will be decided by the heart and surgeon. Any other concern?
Is it serious? Is it serious? That is mean I will die?
I appreciate your knowledge, Mr. And I appreciate your words. It is serious if not treated. As I mentioned, it can cause collapse, can cause sometime affect the life sometime if not treated. But as long as we are following you, inshallah, and the team will take care of you. And after fixing this valve, this gate, it will be the symptoms will be decreased significantly. Okay.
Okay, thank you.
Okay. Okay, time is up. Examiner question, please. Dr. Salma, start.
Can you present your case?
We have this 70-year-old gentleman, history of 2 months of progressive course of shortness of breath, causing him sometime dizziness, low cardiac output, and by doing the examination, there is a slow rising pulse and no sign of there is also sign of overload. His lower limb, there is bilateral mild lower limb edema. Putting all this together and with this first aortic area ejection systolic murmur referred to his carotid. Putting all together, he first possibility he has severe stenosis, symptomatic. Okay.
Okay. So what is your differential diagnosis?
My first differential aortic severe aortic stenosis symptomatic. Second one, in view of his risk factors of diabetes, acute coronary syndrome complicated by heart failure. Third one, atherosclerotic, or second one before the acute coronary, atherosclerotic aortic valve. This causes stenosis. Still, there is differential needed.
It's okay. How you will investigate for this case?
Firstly, as long as there is the patient has saturation level is below, we will admit him doing ABCD approach, taking his saturation again, and started the autotherapy. Patient may need diuretic. Then I will start basic lab for him, CBC for anemia, to rule out anemia as a cause of heart failure and shortness of breath. Then basic lab of electrolytes and KFT and LFT and DSR-CRB. Then we'll do urgent echo to rule out structural and valvular lesions and to confirm our diagnosis of severe aortic stenosis. And we have also any infected arthritis, but no sign of this in the history and exam. ECG to rule out arrhythmia and interval changes. Then we'll control heart rate if more than 90. We'll make him on the lower side. And mentioned also diuretic for overload. Then multidisciplinary team of cardiologist and surgical doctor, cardiosurgery, and most reservation in view of his age will take catheter valve replacement in view of his symptomatic stenosis. Mostly he will take trans-aortic catheter valve implantation. Then education and counseling the patient about this, stopping driving and stopping and supporting his surgery and education and counseling about the disease and the prognosis of it.
Okay, so you will do percutaneous coronary intervention before to refer to the patient to surgery. Is it true? Correct?
Again معلش دكتورة بقى sound
You will
بس
do you will do coronary intervention
Yes, yes,
before.
there would be.
Yes.
In view of his age, there is the option of TAVI, transcutaneous. It will be decided by the cardiac surgery, and most of them also do coronary angiograph to
Yes.
be get, and will send also the cardiac marker troponin to rule out the acute coronary syndrome as
Yes.
and
Yes. Very good.
maybe also.
Yes.
Okay.
Yes. Yes.
What the option of valve replacement here?
The
The
first
last
option
question.
in view of his age is a TAVI transcatheter. If failed, sometimes they sit with the patient and they do high risk consent for valve replacement surgically if the family or but first option is TAVI trans.
You mean tissue valve? You
Yes,
mean?
tissue valve.
Yeah,
Yes.
this is my question. What type of valve you will replace? Okay.
Yes.
Okay.
Tissue valve or
Yes, it's a tissue, not a metallic one. Okay.
No, not
yes.
Yeah, time's up. Dr. Salma, you can comment.
والله ما شاء الله. Very nice. Very good.
you, doctor.
Excellent.
Any other comment regarding performance? Dr. Salma, anything missed
Yes.
or the history taking you want to add? Dr. Salma, you
No.
can hear
No.
me?
No. Yes. 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 Uh,
Any comments you
I
want to add regarding
almost
the history?
almost
Yeah.
important thing is mentioned.
Okay. What about knee pain? Is it osteoarthritis?
Yes. This is only not related to.
Distractory. Okay.
Yes. Not related to the condition.
Okay. So the case, give us a summary of the case. What it's aortic stenosis complicated with heart failure, right? You want to add
It's
anything else?
yes. Still now not developing heart failure. It's only like mild edema in like, but no raised JVB, no basal crackle, no tender liver.
What's
Okay.
the cause of lower limb edema?
What?
What's the cause of lower limb edema?
Sometimes it's coming like symptom of it's coming with a symptom of aortic stenosis with mild lower limb edema.
I mean, what's the mechanism?
You should
I'm not
say
sure
heart
what.
failure, Dr. Salma. Supposed
Yeah,
to have
it's heart
yeah,
failure, yeah.
right side heart
I-
failure.
But right side
Okay.
heart failure will comes with other features. I mean, GVB
Yeah,
and
it's JGB. Yeah, I agree for that.
yeah,
So
no need
once
for basal crepitation because it's left-sided. But
left
I
side,
mean, at
exactly.
least raise GVB if there is lower limb edema.
Yes, exactly. I agree with this. If you want to mention complicated heart failure, you have to have some signs of heart failure. Or you can say only dyspnea related to aortic stenosis without heart failure. So the leg swelling here, difficult to say it's not heart failure. With this degree of stenosis, the patient will have heart failure. And it's one of the manifestation. Patient might present with heart failure. Okay. Initially, it will be compensated, but later on, it might be decompensated, and patient will present maybe by ventricular failure, even pulmonary edema, particularly if the valve is tight. Okay. What else we want to mention here? Maybe also pulsating and congested liver, and it will be tender liver. Again, if we have congestive heart failure, particularly the right side. Otherwise, I think the other symptoms and manifestation of the case is clear. The three presentation of aortic stenosis, as Dr. Salma gave in the scenario, dizziness, or let's start by the dyspnea, angina, and syncope. right?
Yes.
Yeah, these are the three possible president. What is the most dangerous one and advanced one?
Syncope.
Yeah, this is the last and advanced stage of aortic stenosis. Patient will present with syncope, loss of consciousness. So you have to expect the patient might have syncope or syncopal attack. Okay. Regarding the system review, again, I can say the same advice if you want to ask, because you interrupted the history taking regarding the systemic review, Dr. Muhammad. You ask, but then you missed the abdomen. You came back to the abdomen and urine. Try to ask them together.
Yes, Dr.
Otherwise,
I am
yeah.
remembering them, but some schools يعني tell that once you catch the يعني
The
as
case,
this
examine the
high
patient. Yes.
visibility, you should finish it early because you don't know maybe some
Okay.
examination.
It's okay. You can postpone the family history and the social history, the job, the smoking. You can ask them while examining the patient. But the system review, why I am saying to take it earlier or before examining the patient, because you might have something positive and you have to examine it. What if this patient presented or told you while you ask for tummy pain or discomfort and he told you, yes, I have some tummy discomfort? Where exactly he will tell you, for example, in the right upper area.
Yes, yes.
So will you examine the liver? Yes, I have to examine the liver as tender congested liver, right?
Yeah.
This is my concept. If you want to do it, then you ask then to go examine back. It will show the examiner that you are disorganized. This is my advice. So I prefer to do it initially to examine the patient once, not to examine him twice. So, or sitting and coming back, then sitting again to take history, then coming back to examine him. It will show the examiner some of disorganized way. Okay.
Right.
Yeah. Otherwise, I think all examination steps done. The history also was good. The differential. What do you think the differential here? Aortic stenosis and?
For me,
Yeah. I'm asking you. What's your?
aortic stenosis complicated by whatever arterial or failure.
Okay. This is the first differential. The second differential.
The second one, acute coronary syndrome, also so, in view of his risk factors, complicated also by heart failure, benign heart failure. I mentioned another one, this aortic stenosis طبعا atherosclerotic or sclerotic type of aortic stenosis.
What is the most close differential to aortic stenosis? And it comes with this age. You have to mention it as differential. Dr. Muhammad?
I am with you, Dr. Bas. I'm
Okay.
thinking.
What? Yeah.
Regarding the heart or another organ?
Yes, it's related to the heart. Something very important to put as a differential to aortic stenosis.
Acute coronary syndrome.
Aortic
Go.
sclerosis.
Perfect. Yeah, aortic sclerosis. Whenever you put.
I mentioned this, Dr. Basim. You are not
Yeah,
with me.
that's why I'm repeating the question. You didn't tell me. Aortic
I
sclerosis
told
and
second
aortic
one,
stenosis.
aortic valve.
You mentioned to me or you mentioned to her?
Yes, I mentioned to you now.
You said aortic sclerosis. Allah, I didn't hear it.
No, I
Anyway,
told, even with Dr. Sarah, I mentioned, I told aortic stenosis, then acute coronary, then atherosclerotic aortic valve. Then I
you
told
said
no.
aortic. You said atherosclerosis. You didn't say aortic sclerosis. I heard atherosclerosis. Anyway, it's okay. Aortic sclerosis in such age is very important to mention. Even it might be in the top if you have the same murmur without radiation to the carotid, as you know. Why? Because this patient in this age, 70 years, mostly the valve will be sclerotic rather than stenotic. Stenosis comes earlier in younger patients, 50s or 40s, okay? This is only my comment. And try not to use some Arabic words. Some comments comes as you said Arabic words, and they know it. They know them that you are talking in Arabic way. Try to
We can't
restrict
stop
or
it, Bassem, whatever they do.
sorry.
We can't stop it, whatever they do. We
Okay.
can't stop it.
Yeah,
This
yeah.
is,
Okay. I'm giving,
Allah, like, what?
yes, I'm giving advices and try to follow. I don't know how they can minus or they can judge on it, but you have to improve and to avoid it. Okay. Okay. I think we are done with the comment. Anyone want to say anything or comment? Any question? Dr. Inas, comment. Okay, Doctor, I will post your scenario first, Dr. Salma. Then I will read the comments. Dr. Inas, please give me some seconds. Okay, your patient, Mr. Farouk, 48 years old, presented with abnormal kidney function tests. Please examine him and address his concerns. Dr. Salma, 2 minutes, then we'll be back. Dr. Inas, not all right side heart failure present with GVP. Good point. Yes, some patients might take diuretics and the fluid will be, for the volume state will be better than, or the manifestation not will be there. But most of the patient with right side heart failure, they might have raised or supposed to have right or raised GVP. Okay. Leg swelling is an early signs of heart failure. This is what Dr. Salma mentioned. So you might have leg swelling initially. Again, it will depend on the diuretics and kidney function, of course. If the kidney is not impaired, the swelling might improve dramatically after diuresis. And you can see this in real life. You will ask the patient, do you have any leg swelling? She will tell you, yes, doctor, I had maybe 1 week ago. And after diuresis, too much or totally subsided. Okay. So be sure that this volume state or the retention or fluid retention might improve with diuresis. It's on and off, and it depends on again the volume state, the patient restriction to the salt and fluid, compliance to the medication, and the renal impairment or the renal state. Okay. Thank you, Dr. Ines, for the comments.
Dr.
Please.
Bassem,
Yes, sure.
I have a point to clarify about this lower limb edema. As Dr. Salma or Sarah said, it's not
Okay.
due to heart failure. I'm just now reading. There is possibility patient with severe atrial aortic stenosis patient may develop edema or swelling lower limb due to venous stasis from reduced mobility. As this patient has a reduced exercise tolerance and limited mobility, so there is prolonged sitting or and then venous pulling, and it's caused the bent edema. And it's not related to heart failure. Maybe this is what Dr. Salma was wanting.
Yeah, perfect. Okay, thank you, doctor. What's your name, please? Your good name?
Sarah.
Dr. Sarah.
Yeah.
Particularly the old patient or the elderly patient, they might have dependent edema, as you said, with the less movement, with the position even, sitting long time. So it might be as positional one or venous congestion, whatever the cause, but it's not related to the heart failure, as you said. Yes, sir. Thank you to clarify it. Anyone want to comment? By all means, you have to examine the leg edema or the leg swelling in this case. Okay. Don't forget the knees, Dr. Muhammad. Examination of the knees. You might have crepitus, which is sign of osteoarthritis, right?
Yes, Dr. Bassem, missed from me.
Okay.
Dr.
Any
Bassem, I want to
yes.
please.
Sure,
If
Dr. Yes.
If not only in this case, I mean in general, if patient came with osteoarthritis history or may found osteoarthritis, should we do the crepitus or just offer it or ask the examiner to do it? I mean, it may cause pain or something for the patient, and my welfare
No.
will be.
Yeah, I agree with you to offer it, but it's not painful that much. because they are having it for a long time and they are on painkillers. Whenever you have positive finding in the history, Dr. Sarah, please examine it or at least offer it if you don't have time. So if you have time, I would like to do, you will offer. If you don't have time, I would like to do so.
Okay, thank you.
Okay. Also, it's one of the important finding in the history and in the examination. You might have finding. You will feel the crepitus. And they will mention it in the positive comment that you examine the osteoarthritis. The heart,
And
of course, you have
in
to
this
examine.
case, in this
Yeah.
case, couldn't we put like as a differential hemochromatosis as patient have joint pain, heart failure, and I don't know, he said tummy pain or something? Yeah, we can just say it's like liver
What do you
maybe.
think? Is it possible to have the hemochromatosis with this age?
No, at that age it's little bit
Yeah.
far away,
Yeah.
but I mean, yeah, as the collection of data could be.
Absolutely right. If this patient is younger, 50s or 40s with bronze skin, you can put it as a differential.
Okay,
Yes, the patient will have restrictive cardiomyopathy. He will have also pseudo gout and joint pain. He will have the bronze skin and
liver disease
diabetes
of,
as well. Yeah, and the
yeah,
liver and diabetes.
yes.
So
The
it's
patient
fitting.
actually have,
If
yeah,
yeah, you're right. You can think about it. Even you can put it as on the top of your differential, and the case might be there. I mean hemochromatosis. It might be the case. So it
okay,
depends on the age more than the manifestation. Of course, you have to
okay,
think about the manifestation as well.
okay, thank you.
Thank you, Dr. Sam. Ready, Dr. Salma?
Yes, so we can start.
Yeah, here you go.
Yes. Hello.
Hello.
My name is Dr. Sunan. I'm doctor in the clinic today. Can I confirm your name and age, please?
Yes, I am Farouk, 48 years.
Okay. We are here to discuss some issue related to your health condition, examine you and address your concern. Is it okay with you?
Yes, Doctor.
Uh, Thank you. So, during our conversation, if you want to ask me any question, don't hesitate to stop me and ask me.
Thank you.
Mm, Can you tell me what bring you to the clinic today?
Yes, Doctora, since 1 month now, I'm suffering. I feel my effort become more or less. I am have more fatigue, and it is increasing by time. So I came here to
Mm,
see what's going.
mhm. Only you feel that you have no power.
I feel fatigue. My effort not good. I'm going to work.
Okay,
I feel I am taking more sick leave nowadays. My effort is low.
okay, okay, okay. That is mean your effort is low, that you cannot do your daily activity. What do you mean by your effort low?
Yes, doctor, I am waking up at morning, not as my usual to go work. Uh, um, become not easy for me. I feel generally not good.
Okay, okay. Is there any other symptom than this?
This is the main issue, doctora, that I feel that trouble my daily activity and daily lifestyle.
Okay. Uh, is there any change in your water work?
Yes, you are right, doctora. I feel it is decreased nowadays little, and also the color of it little dark.
Dark. Is it all or only at the beginning or only at the end?
All over.
All
Yes.
throughout all. Okay.
Yes.
Is it early in the morning or at the end of the day?
All over the day, the same.
Same. Okay. Uh, is it frothy? Your urine is frothy?
No, I didn't notice this.
Okay. You feel any throwing up?
Yes, doctora, I am my my appetite يعني become little bit affected, not because of this feeling of throwing out. Started since a few days.
Okay. Is there any itching in your skin?
No,
No. You notice any change in your skin that has become more dry?
little bit, doctora.
Okay. 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 Is there any tummy pain?
Maybe no.
Any change in your bowel habit?
I will have it. No,
Okay. Is there any fever? I mean high body temperature.
no.
You notice any change in your weight?
What?
Anyone notice that you are pale than before?
No, no one mentioned this.
Is there any night sweat?
No,
Is there any chest pain?
no.
Shortness of breath?
Yes, doctora, I feel with this fatigue, I am little bit also not breathing well.
Mhm, mhm. You mean that when you do exercise or at rest?
Generally, doctora, even at rest, I feel it is not so good, but more during effort.
Okay, okay. I'm sorry for that. We hope we will help you. Is there any heart racing?
Mm.
Is there any cough?
Cough? Little cough,
Yes.
dry.
Okay. Is there any edema in your face or in your legs or food?
Yes, doctora, I have my leg started to be a little increased inside both leg.
Okay, okay. With the same time with this symptom? For
No,
how
this
long?
is this has become nowadays not from the first, not with my first feel of fatigue, easy fatigability. Just maybe few days back only.
This now 2 days ago.
Yes, few days back, yes.
Okay. There is a swelling in your foot.
Yes,
Okay, okay, okay. Is there any headache,
no,
memory problem?
no.
Is there any weakness?
Weakness, no,
No.
no,
Okay. Is there any swelling in your neck?
no,
Any weather preference?
no.
Any joint pain or stiffness?
Yes, doctor, sometimes I have some pain come and go, but not significant. I am taking for it some painkiller and become okay.
Is there any skin rash?
I remember a few weeks back, some rash come in my leg, but only one day and go, not continued.
Okay. Is there any family history of similar condition?
You mean what, doctor? What similar condition?
I I mean in your family. Is any one of your relative, brother, or in your family? I mean,
What condition,
feel
doctor?
same
You
problem?
mean what?
Any
What?
any any kid any kidney problem in your
No,
family? Okay, okay. Even no also cardiac problem in your family. Okay. Uh, is there any past medical history?
medical history.
Yes.
I have diabetes and controlled uh, on tablet.
Mm-hmm. Now it's controlled.
Yes, controlled. I follow it well.
For how many years?
5 years.
Okay. Okay. You use any medication now?
No, only for diabetes. And sometimes for my joint pain, sometimes I take this painkiller. But otherwise, no.
Okay. Can I ask you some social question?
Mm.
What do you do for living?
I'm accountant.
Okay. With whom you are living?
My wife and 2 kids.
Okay. Do you drink alcohol?
No,
Any recreation drug use?
no,
Do you smoke?
no.
Do you drive?
Yes, doctor, I am driving. No problem for me. Only feel some
Okay.
fatigue.
Okay, good. Is this symptom impact in your life?
As I mentioned, doctor, I feel my effort is low. I am taking some sick leaves. They will affect my job.
Okay, no worry. We can give you more days for sick leave until get well soon.
Doctor, thank
Any surgical history?
you. No.
Okay. Can I examine you?
Yeah.
I want to see your hand for any clubbing, any palmar erythema.
And this is okay.
Okay. What about eye? Any jaundice, eyes, both jaundice or pallor?
No, normal.
Mouse, any candidiasis, gingival hypertrophy, oral stomatitis.
No.
Okay. Can I examine your abdomen?
Yes. What you want?
I want to examine for do firstly inspection. Is there any
No masses, no
scar or
swelling.
any masses, any mass or
No masses, no score.
okay, any organomegaly? I mean for any spleen or any kidney enlargement,
No,
palatable both kidney or not?
no.
Okay. I will listen to heart, first and second heart sound, and if there is any murmur,
Murmur? No.
okay. I will also examine also lung for any basal crepitation.
Yes, some fine rails there.
Okay.
Only basal.
Uh,
Not
only
changing.
only basal crepitation.
Yes.
Then I will ask you to cough. Is it changed after coughing or same?
No, not changing.
Okay. So I will examine also for lower limb, any edema.
Some edema are up to below knee, beating. Fine.
Up to knee.
Up to below knee, mild.
Okay. 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 So you have any concern?
Yes, doctor, I need to know what's happening for me and it is serious.
Uh, I highly appreciate your concern. So from my history and examination, that indicate there is a problem in your kidney or kidney disease. You have the condition need to follow and do some investigation and some scan, and most probably you have some issue related to your kidney.
It is serious, doctor.
So Yes, I highly appreciate your concern.
So what is 2 minutes left?
I appreciate your worry, but after investigation, I'm doing renal function and doing also urine analysis, and we will evaluate your kidney function. Is it on kidney failure or any protein in urine? And we will give you feedback about diagnosis.
Okay, Doctor, thank you.
Thank you.
Still 1 minute and 25 seconds. Do you want to
You
examine?
have you.
Okay, carry on. What you want to ask? Concerns?
Yes, I mean, is there any other concern?
No, Doctor, thank you. I will wait to update me by the result.
Okay. Okay, thank you.
1 minute left. If you want to go to the examiner question, we can start.
Okay, we can start examiner.
Okay, here you go.
Tell me your positive finding and differential diagnosis.
Sorry, what?
Your positive finding and differential diagnosis.
Okay, 48-year-old presented with feeling fatigue, and there is also shortness of breath and lower limb edema, and past medical history of diabetes control on medication 5 years ago. Um, um, uh, my differential diagnosis is mostly acute kidney injury or diabetic nephropathy. But again, is that the diabetic is controlled. Maybe glomerulonephritis, maybe uh, uh, kidney stone. But again, is that no renal colic? Mm,
The cause of acute kidney injury.
I forget only one thing in the history, that vital sign about I didn't do a blood pressure. This is a very important also to check blood pressure for this patient.
Blood pressure is 150 over 80. No
Okay,
position change.
okay, little bit. Maybe also other differential, maybe polycystic kidney, but again, is that no family history and can be excluded by abdominal ultrasound.
Okay. What is the cause of acute kidney injury?
What?
Cause of acute kidney injury.
Cause of acute kidney
You,
injury?
you told the first differential acute kidney injury, right?
Yes, yes,
Usually acute kidney injury have a cause.
yes, yes. Um, mm, maybe diabetic is a cause, or infection, or any hypovolemic cause.
Found any evidence for all these causes? No fever.
Uh,
Patient only just a few days
no,
start, like you mentioned.
mention no fever, no high body temperature, no fever.
So still the acute kidney injury not explained. Okay, doctora. After that, how you manage?
Uh, I will first I will investigate the patient by doing renal function. Doing firstly full blood count, renal function, inflammatory marker, and also liver function. And I will do also some scan, uh, ultrasound, abdominal ultrasound.
Yes.
After that, we will evaluate.
Treatment.
Treatment. We will do to both the pharmacological and non-pharmacological. Non-pharmacological, we will educate the patient and counsel him about that you have some kidney issue, and uh, if shortness of breath is more, we can support the patient by some medication to relieve dyspnea until all investigation and reach diagnosis.
Thank you, Doctora.
Thank you.
Still there 30 seconds. I will ask here some question, Dr. Muhammad.
Okay, Doctora, اتفضل.
What could you do as an invasive test if you want to diagnose this patient? Invasive test. Give me
Biopsy.
in one. Yes, perfect. So renal biopsy. You mentioned AKI or acute kidney injury. Is it diagnosis or it's a complication? Or it's yeah.
It is diagnosed or for underlying condition. There is a problem, and this is like complication.
Okay.
Complication
Give
of
me in one term what you have in this patient. I will give you three options. Okay. Is it nephritic? Is it nephrotic syndrome? Is it nephritic syndrome? Is it mixed? The last question.
mixed, because there is edema and there is also a little bit high blood pressure. So
Okay. Okay, the most common cause of mixed or nephrotic with the hematuria?
um, um, mm,
Do you know?
no.
Okay, in this scenario, what do you think can be fitting particularly?
You mean for diagnosis?
Yeah. What could
For
be the reason of glomerulonephritis, for example, if you suspect it?
I suspect diabetes. As all,
Diabetes will be
as
as
all.
long term. What other possible? Do you think the painkiller he's taking could be the reason? What we call it?
Uh,
Okay, analgesic nephropathy. Could be,
yes, yes.
could be allergic nephropathy and glomerulonephritis. Dr. Muhammad will tell us what the possible case. Now he will comment. Thank you,
Yes,
Dr.
but
Sam.
the patient didn't mention that took analgesia.
No, he said I'm taking.
I mentioned twice, Doctora. I try to guide
Yes.
you. I mentioned twice. You didn't even ask me what is this medication.
Yes. And for how long you are
Because I
taking?
listen only one medication that only for diabetes.
No. Even
No,
during
he
the
mentioned.
medication, I told you I am taking medication for diabetes, and
Yes.
every time I have joint pain, I am taking painkillers. This twice I'm telling you.
Oh, sorry. Allah, I didn't listen.
It's okay. I just
Okay,
learned
okay.
from the mistake. Dr. Muhammad will comment, then I will comment.
Okay,
Okay.
thank you, Dr. Bassem. Thank you, Doctora, for
Thank you.
Dr. Bassem. You start the case. Doctora asked everything. يعني from the first she told me that it's ferocity. No, so it's not nephrotic. Then she asked it is any blood in urine. I told I don't remember. She asked me clearly, frankly, blood or not. But if she asked me, I will tell her no. It's only little dark. So it is not hematuria and not ferocity. So it is mixed or intermediate in between. So if I told frothy, you will take the scenario from the nephrotic causes, from organ failure and other lupus and other causes like diabetic amyloidosis, rheumatology, malignancy. But I didn't mention nephrotic at all. And but not bloody, the common thing. She asked me also if it was at morning or at any time. I told her no. So no, and they asked me about fever. So it is not post-infection, not hemoglobin nephropathy, not she asked me also any weight loss. I told her no, so it is not malignancy, no surgical cause. So we are now on two things. It is rheumatology or drug induced. Mostly this. يعني she exclude all the other. But the issue here, she didn't follow this. She's still searching for the same that she is excluded. And also she excluded the pulmonary cause, pulmorenal. She excluded. She asked me any cough in the. I didn't. I asked her. I answered it. So it is now rheumatology and drug induced. If she told from the beginning drug analgesic nephropathy, it is the diagnosis. It is called tubular interstitial nephritis. And besides the patient, she can tell I need urine dipstick now, and maybe the examiner he will tell you no RBCs. So he will exclude for you any hematuria. So it is tubular interstitial or the other like rhabdomyolysis and tumor lysis, and you excluded. I told you no change of my life. I am less effort and no exercise. So first diagnosis the tubular interstitial. And where is the case? As mentioned, no hematuria, no nephrotic. And I mentioned, she asked me about rashes. I told her I have rashes, but come one day and go. And this is going also with the analgesic and the tubular interstitial nephritis. She come slight rashes and joint pain. Maybe the underlying there some rheumatology, and mostly which come with mixed, not frank hematuria, not frank nephrotic. It will be lupus, or you can. I need to exclude any rheumatologic cause of glomerulonephritis. Last thing, the complication. You started by the complication. The patient already, if you ask why the patient become lower limb edema, bather rails. طبعا patient have acute kidney injury. He has خلاص analgesic nephropathy and started to be oliguric. He started to be has complication of the acute kidney injury. He started to be overload. He become, and you asked me about throwing out. He started to have throwing out, so he has uremic symptoms. No need to all the cases to have the full. No need to Allah. I will tell you I have itching, I have everything. No patient will tell you everything, and this is the real life of us. He will tell you 1 or 2 key, then you will. So the patient diagnosis tubular interstitial nephritis, underlying rheumatology cause of glomerulonephritis. I need to rule out the most common is lupus. Patient complicated by acute kidney injury. The investigation. Patient now in uremic symptoms. Urgently, I need to admit the patient. I need to do EPG. I need to do full lab and chemistry. If potassium is high, if started acidosis, I will share the nephrotein if there is any indication for dialysis. I will check his ECG if potassium is high, and echo also for any complication from the acute kidney. To diagnose the case, I need the urine dipstick. I need urine and the blood eosinophil. It will be diagnostic in many cases. I need to do ultrasound abdomen to rule out post or obstructive causes. Lastly, if the patient not diagnosed, طبعا during the counseling, during the concern, you tell him frankly, please stop this analgesia, to take it again. And during the discussion with the examiner and non-pharmacological, I will advise him to stop this medication. Then at the end, if still the patient not diagnosed, I will recommend for biopsy, as Dr. Bassem mentioned, to give us the last differential, the last confirmation for the diagnosis. Let me see now. Anything else, Dr. Bassem? Besides طبعا the basic lab, as you mentioned, TBC for anemia, complication and infection, chemistry and ASR CRB for activity. And the last thing, the underlying. Now we reach the diagnosis, the complication, the underlying. I will send for him at least ANA and rheumatoid factor then we will guide by the rheumatology team if need advanced autoantibodies or more with the biopsy. Besides the non-pharmacological education counseling and stopping the medication. I finished my comment. Regarding the examination, only the GVP didn't ask. And at the end, you told me about the vital. The vital is very important, said patient. You didn't ask about his saturation. Whatever written in the paper outside, if you feel the patient in emergency, you should, vitals and saturation is very important for such cases to know how to deal as an emergent or as a cold case. And you examine the heart, okay, and this rails for the overload of the patient after acute kidney injury. And there is uremic cardiomyopathy, and patient may be already impending heart failure from the uremia. And yes, you examine the abdomen. You should do palatable kidney to rule out this ABKD, and you ask the family history, and you roll it, but it should be palpated, the kidney. And you examine the lower limb. That's all for the patient. And you can ask the patient during the examination, I need to confirm his conscious level is okay by many mental state. The examiner will tell you he's okay, plus you fulfill the patient you're in, not in your. Okay, Dr. Bassem, this is my comment.
Yeah, thank you. Okay, thank you, Dr. Muhammad. Well done, Dr. Salma. I will add just for the investigation urine analysis, what it showed you. What it will show you, the urine analysis.
Eosinophil cast.
Yeah, eosinophil cast. And you can find also in the blood film eosinophilia. Okay, this is very important. The rash, as Dr. Muhammad mentioned, maybe the clue of the scenario. Rash, fever, joint pain, along with the kidney injury. Okay, my comment, Dr. Salma, the jargon, you are using some jargon like cardiac. I wrote it down. Cardiac, you have to say
Yes.
heart.
Yes.
And the other one, yes, edema, swelling. Family history, whenever you ask about family history, try to be more specific. Any family history of note, or if any family history of kidney, because of this complaint was related to the kidney, so you can specify the kidney. Any family history of kidney disease? No.
Okay.
Any family history of note, especially
Hmm?
if he asks you, doctor, what you mean? So tell him as a general or specific. Of note means anything runs in family. In this scenario, particularly, you are worried about adult polycystic kidney, so you can say any kidney disease running in family, particularly, okay? Back
Okay.
to the other comment. The system review also up and down. I want to be more organized, but the constitutional symptoms followed by past medical history, surgical history, ask whenever you have positive, analyze it more. I had joint pain and I'm taking an analgesia or painkiller. May I know what, for how long, and give me the name of this painkiller. What about the joint pain? You have to analyze it. Yes, joint pain. Tell me more about this joint pain. Is it improve the movement, worse with the movement, or the opposite, improve the rest or worse with the rest? So is it mechanical or inflammatory? You have to know it. Once you have inflammatory, you have to ask about stiffness in other joint, any back pain, any other joint affection. Okay? Because it might be related to the case as post or related to the rheumatological condition like SLE, rheumatoid arthritis. Either amyloidosis can cause, or even the medication itself can cause. So you have to know what you are dealing with. Is it related to the underlying connective tissue disease, or just mechanical pain, and he took medication for it, which lead to our case today, either by interstitial nephritis or even by sometimes they have ATN, acute tubular necrosis. And non-steroidal as well can cause membranous glomerulitis. So you have a lot of conditions in the kidney related to the painkiller itself. Okay? So be
Yes.
sure what he is taking. You have to ask him what's the name of this medication. Did you take it by medical advice or by yourself? Is it over counter? For how long you are taking? Here you can put it as a first top differential, and the examiner will give you the good mark and the differential. And you know the case, you catch the case. But if you miss this part, you might give all the differential, but you will not give the exact differential in our case today. That's why you were confused. What is the case and what are the findings? Yes, you catch it as acute kidney injury. Acute kidney injury is a finding, not a disease. Acute kidney injury, big term, you can divide according to the level, pre-renal, post-renal, or renal. And here you can have the renal itself. What are the renal causes? Is it pre-renal? What are the causes of pre-renal? So acute kidney injury is a big term, not as a diagnosis. I believe this is a complication or a finding, but you cannot say this patient is having acute kidney injury. Yes, because of what? You have to give me some differential diagnosis to the acute kidney injury, not only as a finding. Of course, he has finding of acute kidney injury in the form of oliguria, uremic state, or hyperuremia. But what is the underlying cause? What do you think the cause will be? You have to give him a clear and not clear, yeah, at least a differential which makes sense. In this scenario, by the history of painkiller history or the medication or over-counter medication, you can give directly as indicated or as a differential related to this medication. As Dr. Muhammad said, you have immediately to ask him to stop his painkiller. Please don't take it without medical advice. Okay, it might be the cause. Doctor, will I have failure because of my condition? So you have to be also here diplomatic. You don't know what will happen in the future. We have to run some blood tests. We have to do scan to your kidney, and we will update you. Is it possible to have renal failure, Dr. Salma, in this patient?
Yes.
So yeah, always put it as possible, even if low possibility, but still it's one of the possibility. Patient might end up with dialysis, particularly if he's not stopping the offending medication. Okay, we have a lot of patients
Yes.
in real life. They have kidney injury, sorry, end-stage renal disease because of painkiller or because of the analgesic over-counter medication. Okay.
Yes.
Yeah, in general, you did well. The examination also was good, but please be systematic while taking the history. This is my comment. And whenever you have positive finding, analyze it. Don't skip it.
Okay.
Okay.
Thank
Thank you,
you.
Dr. Salma.
Complete,
Thank
please,
you
I
very
need to
much.
complete.
Yes.
Can you listen?
Yes. Yes. Yeah.
Yes, but some after treating the emergency, as we mentioned, as acute kidney injury, we will treat it and diagnose the case and send the investigation, the specific that we mentioned, urine eosinophil, blood eosinophil, and at the end you will mention the biopsy, and we can consider steroid after advice from the nephro. Very important to consider steroid at the end. This بس missed from me. Okay.
Yes. But it will be proof after stopping the medication. This is what
Yes,
I think. Yeah. So it's
minimum.
self-limiting. Yeah. Okay. Maybe the exam will ask you: is there any role for steroid in this scenario? Yes, you can say. Uh, if you are sure about the answer, say it clearly. Yes, there is a rule. If you are not sure, and this is also our rule in all patients, if you don't know, please refer to the specialist. I will refer the patient to the renal or nephrologist, and he will decide. You be safe, better than mentioning something might harm the patient as an answer. Okay. Thank you, Dr. Muhammad and Dr. Salma. Any question? Dr. Muhammad and Salma, before moving to the discussion?
Thank you very much.
Most welcome. Okay, now open the discussion for all. Anyone want to comment or add differential or to clarify any point? Nephrology as a branch basis has a lot of variety of cases. On the top of them, adult polycystic kidney disease, either presentation with hematuria or flank pain or fullness or subarachnoid hemorrhage as opposed headache. Okay, but mainly hematuria as top of your presentation. Add to them the glomerulitis. Okay, the glomerulitis itself, as we know, you have to differentiate: is it nephritic or nephrotic? And mostly, if you don't have any clear cause, you can say this is membranous glomerulitis. It can be as idiopathic. It comes in young patient. Sometimes it could be related to medication, non-steroidal. Sometimes related to the infection, like hepatitis B, hepatitis C, syphilis, or malignancy or connective tissue disease. Okay, this is as membranous, the most common presentation of nephrotic syndrome. The other nephrotic syndrome will be minimal change, which comes in younger patient, maybe children or even young adult. And as we know, selective proteinuria or albumin in urine, patient might have complication of hypoalbuminemia. Even thrombosis might happen with this condition. Frothiness of the urine, the main presentation of both condition, proteinuria. Then we'll go to the nephritic syndrome. Nephritic syndrome, you have big two terms and differential: post-streptococcal and IgA nephropathy. This is in the top of them. This is a post-infection. Don't forget the pulmonary renal. Patient will present with pulmonary symptoms, short of breath, hemoptysis, epistaxis, and kidney or hematuria. So these are the possible nephritic syndrome. You have blood in the urine. Of course, you have to put adult polycystic kidney disease or renal stone, trauma, injury. All the things can present as hematuria or nephritic syndrome. The mixed form, you can put amyloidosis, you can put post hypertensive, you can put diabetes. Okay, don't forget the SLE as well, the advanced one, proliferative, and the membranoproliferative glomerulitis. It could be presented with this, and at the end, focal segmental will be the end stage of the systemic lupus. This, in summary, how the kidney or the nephrology cases will come. Nothing more than this. But transplant, of course, it's a big term in the renal case or in the abdominal station. Transplant or post-renal transplant with all the complication of post-transplant. But the underlying, in the top of them in younger patient, adult polycystic kidney and diabetic in younger patient, or glomerulitis and hypertension. Okay, this is our case today. Interstitial nephritis is not that much common, but still you can have it as post-medication with the rash, fever, joint pain, and as we saw in this scenario, acute kidney injury. Clear for all? Anyone have any comments or question? Any suggestion? So clear? Satisfied all?
Yes, thank you.
Okay, thank you, Dr. Muhammad, Dr. Salma. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.